Hi guys, this is Dr. Irshad Mohsin here. I hope you guys are ready for the examination. I think it is there in a couple of days. Don't get anxious. You guys are ready for the battle. I'm just helping you out by making an ortho webinar so that it is a quick revision for you guys. I'm sure many of us are good in orthopedics, but still we are failing to get a three-pointer in the questions of orthopedic. Even though we know in and out of orthopedics, but still we are missing on a three-pointer. There are very few minor mistakes which we are doing in it. I hope you will catch those mistakes by the end of this webinar. Alright guys, so let's get started. Ortho revisited. Okay, there are some general rules to answer orthopedic questions. Okay, always remember when you have an x-ray or a picture, when asked to describe it with side, orientation, displacement. Everything should be there, especially the side. When you don't mention the side, you lose half a mark. And there we are losing marks. Okay, always remember to check, be it fracture, dislocation, or your nerve blocks. Always remember to check pre and post neurovascular check. Immediately you need to check the neurovascular examination of the distal part of the affected limb. Please do not forget to mention neurovascular status of the distal part of the affected limb. Okay. Analgesia. Remember your morphine, your nerve blocks. Always remember your nerve blocks in orthopedics. And just don't write analgesia. As I said previously also, you need to write what you're gonna give. Don't just write analgesia. Remember appropriate x-rays. At least you need at least two views of x-rays. Okay, special, remember your special views like Judith view, skyline view, Y view, frog leg view. Judith view to see your acetabular fractures, skyline view of your scapula and your patella, Y view to differentiate between your anterior and posterior shoulder dislocation, frog leg view in your SUFI. Always remember your consent. Reduction should be always done under procedural sedation. You can use Entonox or Propofol, anything. Post-reduction neurovascular checks, as I said, is important. If you have a dislocation, you need to, once you relocate, you need to check neurovascular status. You need to immobilize and take a repeat X-ray as a proof of your relocation. Okay. Always remember immobilization in all your dislocation and fractures. And if you have dislocations or fractures of lower limbs, you need to consider DVT prophylaxis, low molecular weight heparin, and use of crutches. Use, if we forget to mention this, use of crutches, low molecular weight heparin for DVT prophylaxis. Now, all of your management questions in orthopedics have to have a disposal plan. It should either be a fracture clinic follow-up or it should be an orthopedic referral, immediate orthopedic referral. Okay, so remember these things. These are the general principles to answer your orthopedic questions. I'm sure these things, if you follow these things, you are going to score a three-pointer in orthopedic questions. There's no doubt about it, because I know every one of you know each and every fracture they're going to ask in the examination. Okay, please remember these rules so that you score a three-pointer. Okay, elbow dislocation. The picture is given. I'll ask you to diagnose this. People will write posterior elbow dislocation, but they forget to mention the side. Okay. Next, if they ask what is the immediate thing you do next, is check the distal neurovascular status. You should also mention distal neurovascular status of the right upper limb if this X-ray is given. Please do not forget to mention the side. Okay. And as I said, in all dislocations, pre and post reduction, distal neurovascular check has to be performed. What are the major structures that can get damaged? Are brachial artery, median, ulnar, and radial nerve. These things can get damaged. There are two methods of reduction, but in the exam, if asked for the method of reduction, just write one. Don't give options to the examiner. As management, you are responsible for analgesia. Just don't write analgesia. This is just for your learning sake. You have to write what you're gonna give. You have either an intravenous paracetamol or you're gonna give morphine. Okay? Analgesia is important. Huh? Reduction techniques, I'll speak in the next slide. Then once you have reduced, you need to put a back slab in a 90-degree flexion for 3 weeks with fracture clinic follow-up. Okay. Now we speak about the two methods of reduction. Okay. One is flex the elbow at 60 degrees with countertraction on the upper arm. Pull the fully pronated forearm at this angle. Okay. This is one thing. The other is lever the olecranon forward with both thumbs while holding the elbow flexed and while an assistant provides traction on the forearm. See this picture on the right side. This picture on the right side is your technique, this one. Okay. If you can come up with a better sentence formation, you stick to that. Otherwise, remember these things. Okay. Let's move ahead. Okay, now pulled elbow. Pull elbow, basically, this is tested more in your OSCE examinations, but you never know. You can put up a question about pull elbow. What do you mean by pull elbow is in pediatric age group, when there is a pull, for example, in this picture, as you can see here, in this, when there is a pull, either by any of these three mechanisms in the picture, there are chances that the radial head gets dislodged. This is the annular ligament, as you can see. There are chances that the radial head can get dislodged from the annular ligament and displace and sublux downwards this way. So this is known as pulled elbow. Basically, it is a clinical diagnosis. Parents come with the child with the complaints that your patient is not moving the elbow. So in pediatric age group, you should think of pulled elbow. It is a clinical diagnosis. Usually you do not require an X-ray to diagnose it. Reduction is done by two methods. Again, you have to write any one if asked in the exam. It is for the one method is flexion, flex the elbow at 90 degrees by providing supination. Flexion and supination is one method, or flex the elbow and hyperpronate. Okay, these are the two methods by which you can reduce the pulled elbow. After you reduce the elbow, you need to check the distal neurovascular status. One, then you need to observe the child for some time, whether the child is again starting to use that elbow. If yes, the child is moving the elbow normally, discharge the patient and advise the parent against all these three mechanisms which are there in this picture on the right side. Tell them not to pull the elbow. Okay, and provide some analgesia and discharge them. If not, if the child is not moving the elbow normally, then you need an X-ray to see for some associated fractures. Okay, let's go. Now, either one of this is going to be in your examination. It is either an on the left hand side you can see an anterior shoulder dislocation. This the femoral head is not correlating with the glenoid cavity, as you can see here. Here is your glenoid cavity and here is your femoral head. They are not in place. This is the shoulder. This is your anterior shoulder dislocation. Okay, on the right hand side of the screen, you can see there is some problem with your humerus. Your humerus is not looking like a normal humerus. Now, if you outline this, I'll outline in a much better way. Okay, if you can see the humerus, the head of the humerus looks very abnormal, though it looks very close to the labrum, but this looks abnormal. But they can ask you, what is this sign you see here? This sign, what you see here, is known as light bulb sign. If you can, if I draw the outline, it comes in the shape of a light bulb. This is the light bulb sign, which is usually seen in posterior dislocation. Okay, this question is going to come in an exam. What sign is associated is the light bulb sign. Okay, how would you differentiate between anterior and posterior dislocation through an X-ray? Is you get an X-ray of Y-axis of the shoulder affected, and there you can differentiate whether it is anterior, posterior, or inferior shoulder dislocation. See, as I said, this is known as a light bulb sign. Okay, what are the common complication associated with shoulder dislocation is, one, you can have an axillary nerve damage. You can have a head of the humerus fracture. Okay, now you can have an Hill-Sachs lesion. This is nothing but a depressed fracture. As you can see on the right hand side top here, there is a depressed fracture on the posterolateral area, which is known as Hill-Sachs lesion. And you can have a Bankard lesion. You can see here there is a labrum tear. There is a labrum tear. This one. This is your labrum tear. This is known as Bankard lesion. Now people are confused which is Hill-Sachs and which is Bankard. So when you draw a scenery, when you were a kid, you used to draw a hill and a bank of river. So hill is at the top, river bank is at the bottom. So remember it that way. Okay. So reduction methods, I don't think they'll ask you to describe the method of reduction, but if asked, remember any one method. I prefer Koch's method, that is your team approach, traction, external rotation, adduction, medial rotation. Team, it is mnemonic is team, don't write team, but to remember this procedure, remember it as team. So Hippocrates, Paso, Milch, Koch's, Cunningham, Stimson's, all the any one of these you can write. Okay. Management is your analgesia, immobilization. How can you immobilize? You can use a shoulder immobilizer, or you can write your collar cuff, and you need to give an orthopedic follow-up for these patients. You don't admit, but you arrange for a follow-up or fracture clinic, follow-up at fracture clinic, and discharge them. Okay. Knee dislocation. Knee dislocation is very important because all knee dislocations are admitted whether or not the neurovascular compromise, because the major things which can get damaged in a posterior knee dislocation are, first is your popliteal artery, second is your popliteal vein, or your common peroneal nerve. Okay, but most important is your popliteal artery. All should be admitted due to risk of popliteal artery injury. Okay, the relocation is very simple, just a longitudinal traction in slight flexion of 15 degree will relocate it. Okay, but if you can see a picture, I've given you a picture at the bottom. If you see this sign This looks like a dimple. How a dimple comes on the cheek. This looks a dimple on the knee. If there is a knee dislocation with this sign on the knee, this is known as dimple sign. This means that your medial condyle has penetrated through the medial collateral ligament and has stuck over there. So it is unlikely that you can relocate this dislocation. This needs an orthopedic referral. But if it is a simple knee dislocation, you can relocate it. But if you see a dimple sign, you cannot relocate it. You need an orthopedic referral for that. That needs a surgery. Okay. Now, let's assume you have a posterior knee dislocation without a dimple sign. You have reduced it by this method. You are still going to admit that patient for observation. If you have, after relocation, if you have neurovascular compromise, immediately you're going to refer to the ortho and vascular surgery. Okay. If you do not have any signs of neurovascular compromise, you need to admit and you have to do an serial ankle brachial index measurements. If your ankle brachial index is less than 0.9, you need to arrange for a CT angio plus a vascular referral. If it is above 0.9, that is normal. Okay. So what is this sign called? Again, it is a dimple sign. If you see this sign, immediately refer to ortho. Don't do anything. Okay, this has not been asked till now, but can come as a question. What do you see is a patella dislocation. You can see over here. The patella has been dislocated towards the lateral side. These are mostly associated with sports injuries. Okay, majority of them are lateral dislocations. The management is simple: analgesia, reduction with procedural sedation. How do you reduce is you push the patella medially while extending the knee. Okay, it's a simple method. Then you get an x-ray done, AP lateral or a skyline view to rule out fractures. Okay, once you have ruled out a fracture, you need to put an above knee cast and a fracture clinic or an orthopedic follow-up. You discharge them with the advice of using crutches, DVT prophylaxis, analgesia, and of course non-weight bearing and rest. Okay, now this is a tongue twister to me. Since we were talking about sports injuries, this is also a very common sports injury. Usually in the scenario they might give you a presentation of a football player who has been tackled and has presented to you in the department with a knee pain. Okay, so there is a triad called O'Donoghue triad. Okay, it's a tongue twister. O'Donoghue triad, in which there is a medial meniscus in tear, anterior cruciate ligament tear, medial collateral ligament tear. This is a triad of this. These are 90% of the time these are associated with the sports injuries. Investigations are initially in the emergency department. You get an x-ray done to rule out any fractures. Of course, later on MRI is done, but that is done by the orthopedics, not by us. We are responsible for the x-ray, AP and lateral view of the affected knee. Our management is analgesia, immobilization in a knee immobilizer, and orthopedic referral. Whenever I say orthopedic referral, it means orthopedic referral now. Whenever I say ortho follow-up, means you're going to discharge the patient and tell them to follow up in the orthopedic clinic or fracture clinic. Okay, I think many of us were freaked out seeing these pictures in the examination. So don't worry. There is a difference between ankle dislocation and subtalar dislocation. What you see here in these pictures is this. There is a dislocation. This is this. Oh, the red line I am highlighting is your talus. Okay. There is a dislocation just below your talus. There is a dislocation here. In your ankle dislocation, true ankle dislocation, there is a dislocation. I will put another color. There is a dislocation just below the tibia, just below your tibia and fibula. When you have a dislocation just below your tibia and fibula, that is your true ankle dislocation. As I have highlighted in red, if you have a dislocation below the talus, it is a subtalar dislocation. In the exam, they might give you a dislocation and you have attempted a reduction, and post reduction film they'll either give you a lateral x-ray, they like the second one, they can give you a lateral view or an AP view in which you are supposed to identify whether it is a subtalar or a true ankle dislocation. Whenever post reduction you see some abnormality as these arrows are shown, if you see an increased space as an increased space here, or there is a disruption here, as you can see the talus looks embedded into the calcaneum. This is abnormality here or in this one. If there is an increased joint space here or increased joint space between your talus and your calcaneum, then this means this is an indirect indication that this is a subtalar dislocation. Okay, so remember this. When you after reduction, if you see increased joint space here or these arrows which are showing you the increased joint spaces, these are your subtalar dislocations. Here, whenever you see a subtalar dislocation, you have to give an orthopedic referral. Okay, next. This is your true ankle dislocation. As I said, if there is a dislocation just below the tibia and fibula, see, your this is your fibula and this is your tibia. There is a dislocation just below it. The whole talus is twisted. This is your true ankle dislocation. I'm repeating it again. If there is a dislocation just below your tibia and fibula, that is your whole talus is twisted, that is your true ankle dislocation. And if there is a dislocation below the talus is in line with your tibia fibula, but the portion below the talus is twisted, that is your subtalar dislocation. This is the lateral view. As you can see, there is a dislocation just below your tibia and fibula. This talus is dislocated behind. This is your true ankle dislocation. Okay, I don't think there should be any more confusion regarding this between your subtalar. Okay, ankle dislocation is an orthopedic emergency. Usually they are associated with some fractures. And always remember, when you think of ankle dislocation, you need three views of X-rays. That is your AP, lateral, and mortise view. Okay. Now, they might ask you a question on what are the indications of immediate reduction in emergency department other than neurovascular compromise. Those are gross deformity of the ankle, severe pain not responding to strong analgesia, skin tendon dislocation for more than 24 hours, open fracture dislocation. Yeah, now your question might be, how can, if there is an open fracture, why do we need to reduce it? If it is an open fracture dislocation, you need to reduce the dislocation, okay, and immobilize it. Then you need to admit in the ortho for your ORIF. Okay. Now the question comes, how do you reduce it? Okay. It is simple. Keep your knee partially flexed. With your non-dominant hand, support the patient's calf. Okay, and with your dominant hand, grasp the heel of the patient and just pull it. It will relocate. It is simple. Then you need to recheck your distal neurovascular status. Immobilize with a long leg back slab. Ortho follow up within 3 days. Okay. Here you can also think of your DVT prophylaxis and use of crutches. Okay. Now, lunate and perilunate dislocation. Okay. I think there is a little confusion, but if you get the concept right, it is simple. As you can see here, this what I have highlighted, the capitate, lunate and your radius fall in the straight line in your lateral view. In your lateral view X-ray, capitate, lunate and radius fall in a same line. Now, if you know this, everything else gets simple. Now, on just right to the picture I have highlighted, you can see your this is your capitate. Let's mark it as C. This is your lunate and this is your radius. Okay. Now, if you see these three are not in a straight line, which bone has dislocated is your lunate. This is also known as spilled cup sign. As you can see, the lunate looks like a cup and it has spilled. It is turned. It is dislocated. This looks like a spilled cup. It is also known as spilled cup sign. Whenever you see this spilled cup sign, it is a lunate dislocation. Whereas to the right side, this is again your capitate. This is your lunate. This is your radius. Now, if you can see, the lunate and radius are in one line. Capitate is somewhere else. And if you see this cup is not spilled. It is there in its position. That means it is not a lunate dislocation. It is a perilunate dislocation. Okay, now I think you should be clear on this concept. When you have a cup, imagine lunate to be a cup. If it is spilled, it is a lunate dislocation. If it is not spilled, it is there in position, then it is a perilunate dislocation. Let us see an X-ray for example. Here if you can see, this looks like a spilled cup. Can you see this? This looks like a spilled cup. This is your lunate dislocation. Okay, here is your radius. Let's mark it R. Here is your capitate. This is your lunate. So lunate has been dislocated. This is your lunate dislocation. Now, whereas at the right side picture, if you see, this is your radius. This is your lunate, but your capitate is here. Okay, if you see, the lunate is not showing a spilled cup sign. It is in position. It's looking like a cup. But your capitate, lunate and radius are not in the same line. If you see, this is the axis. They are not in, I'm sorry for the crooked lines. They are not in a straight line. So this is your perilunate dislocation. Okay, I think it should be clear. So that's it with the dislocations. Now let us move to the fractures of the lower limb. Quick question. What is the next step in pain management? What is the diagnosis? What are the required bedside tests to be done? What are the standards set by the College of Emergency Medicine for this injury? Give 4 differential diagnosis for the fall injuries. 80-year-old female who lives alone presented to ED after a fall in the morning which she does not remember. She is unable to walk, stand or bear weight over the right lower limb. She is a known case of hypertension, diabetes, coronary artery disease on ramipril, losartan, sulfonylureas, aspirin and oral nitrates. Her present observations are BP 140/84, pulse rate 90, saturation 98, respiratory rate 16, temperature normal. Your resident has given intravenous morphine and requested an X-ray of pelvis, which is given below. She still gives you a pain score of 7 by 10 and has normal distal neurovascular examination. Okay, what you can see here is there is a fracture of right neck of femur. Okay, now the question here is, what is the next step in your pain management? So some people might argue and say we can repeat the morphine, but as an examiner, what I'm expecting is you go ahead with your fascia iliaca block. So the answers are: perform the fascia iliaca block on the right thigh. Again, I said side is important. Okay. Now, what is the diagnosis? Is your right subcapital fracture neck of femur. Okay. Even if you don't write subcapital, right fracture neck of femur is good for me. But if you just write fracture neck of femur without the side is not good enough for me as an examiner. So side is important. What are the bedside tests? What you can do in this patient is ECG, ABG, blood glucose, urine dipstick. Now, what are the college guidelines for this kind of injuries? Royal College of Emergency Medicine has set guidelines for fracture neck of femur. They call it as fast tracking of these patients. Fast tracking. Okay, you should have an early pain scoring, analgesia, and reassessment. Okay, early X-ray, 90% within 60 minutes of arrival. 90% of your patients should get an X-ray within 60 minutes of arrival. Okay, then they said early referral. Okay, within 2 hours your orthopedics should review the patient. The fourth thing what they said is prompt admission. The patient should reach the ward within the 4 hours of arrival. So now let's reassess. Patient comes to you. These are the college guidelines. Patient comes to you. You should quickly assess the pain, give your analgesia and reassess. And if the pain isn't subsiding, the best way in neck of femur is fascia iliaca block. Okay. Next, early X-ray. Within an hour, you have to perform the X-ray. Within 2 hours, your ortho should review. Within 4 hours, the patient should be in the respective ward. Okay. Next, what are the differential diagnosis of this patient who had a fall? It can be orthostatic hypotension since the patient was on AC inhibitors. Patient could have hypoglycemia, cardiac arrhythmia, seizures, vasovagal syncope, and also you can write as polypharmacy. She was on a lot of medications. Okay. Now, there are two types of fractures. Okay. Those are intracapsular fractures and extracapsular fractures. See on the left hand side, you can see the fracture is within the joint capsule. This fracture over here is within the joint capsule. Now the joint capsule has been marked here and here. If there is a fracture in this area, let me draw a line. If there is a fracture in this area, it is known as intracapsular fracture. If there is a fracture of the trochanter, usually we see intratrochanteric fractures. If there is a fracture of just outside the joint capsule, anywhere here, this is your extracapsular fracture neck of femur. Okay, these are the types of the fractures. Now they are again subdivided into these: subcapital, just below the head; transcervical, intratrochanteric, subtrochanteric, greater trochanter, lesser trochanter. If you can remember and write, well and good. If you cannot, just mention intracapsular and extracapsular. That is good enough. Okay. Now, garden classification, just go through it. Okay. Uh, I'm not a great fan of classification, but if you can remember, which is good. So these is the garden classification you can go through in your textbooks. Now, what the NICE guidelines has said about this is recording to be made in the ED. These are the things you need to assess in the ED in the patient who has presented with fractured neck or femur. You should assess for pressures or risk, hydration and nutrition, fluid balance, pain, temperature, continence, coexisting medical problems, mental state, previous mobility, previous functional ability, social circumstances, and whether the patient has a career. This is stated by the NICE guidelines. NICE states this, whereas we previously spoke about fast tracking. Fast tracking has been said by the Royal College of Emergency Medicine. These things are set by the NICE guidelines. So, management. We spoke about the fast tracking. Okay. Now, management, pain relief. As I said, start with morphine. Fascia iliaca block is good. From there, they can jump into fascia iliaca block also. So, you need to be aware of fascia iliaca block. MRI, if in doubt, that is not a part, that is the orthopedician part. Consider a nerve block. We spoke about fascia iliaca block. Fluid and electrolyte imbalance should be corrected. Anemia should be identified and corrected. Coexisting medical conditions should be noted down. Diabetes, congestive heart failure, any infections, COPD should be noted down. Okay. These are the labs which you need to send: FBC, venous blood gas, urine electrolytes, INR, group and save. Okay, that's much of it. So whenever they can ask, whenever you have a question on fascia iliaca block, what are the potential things they can ask is what drugs you can use, how do you identify the location. They can ask you what do you mean by stop before you block, and they can ask you how frequent will you monitor the patient after you've performed a fascia iliaca block. Okay, there was nationwide guidelines released in the NHS system saying that after you perform a fascia iliaca block, you need to monitor vitals at 5 minute, at 10 minute, at 15 minute, at half an hour. Okay, remember that 5, 10, 15, 30. Okay, what are the complications of your fractured neck or femur? It can be an avascular necrosis if it is an intracapsular fracture. You can have a neurovascular damage, non-union compartment syndrome. All fracture of your long bones or important bones can have a compartment syndrome. Okay, venous thromboembolism, infection, hematoma, post-traumatic arthritis, and chronic pain. Next question. What is your diagnosis? What investigation will confirm the diagnosis and what will you look for in this investigation? What is your ED management? What do you see here? This one is known as Lisfranc bruising. Okay, this is your Lisfranc bruising. Now let's read the question. 25-year-old male jockey fell from a house while the foot was entrapped in the stirrup one day ago. His complains of severe pain in the foot, unable to weight bear since the incident. Today morning he noticed an ecchymotic patch over the sole. This is your Lisfranc's bruising. What is your diagnosis? Is Lisfranc fracture dislocation or Lisfranc dislocation? What do you do to confirm is you do an X-ray of the affected foot. In this case, it is the right foot, AP and oblique view. What do you see is in your AP view, you see whether the medial margin of your second metatarsal is aligning with the medial margin of your middle cuneiform. On the oblique view, it is whether your medial margin of your third metatarsal should align with the medial margin of your lateral cuneiform bone. Okay, so there is a difference. On AP, it is the second metatarsal with your middle cuneiform. On oblique view, it is your third metatarsal with your lateral cuneiform. What you need to do is analgesia, orthopedic referral for your ORIF. Lisfranc fracture dislocation. Okay. Now this one. This is your the green box which is highlighted is your Lisfranc. This green box is your Lisfranc joint complex. Okay. There is a Lisfranc. This red band in the middle, which is highlighted here, there is a Lisfranc ligament in your midfoot injuries. This ligament can be disrupted, and hence the Lisfranc dislocation. Okay, so what you need to see in these kinds of dislocation or fracture dislocation is, as I said, in your AP view you should see your medial margin of your second metatarsal should be in alignment with your medial margin of middle cuneiform. This is your middle cuneiform. This is your medial side of second metatarsal. Okay. On oblique view, it is the third. Now, see, this is your normal. Left side is your normal. The medial side of your second metatarsal is in alignment with the middle side of the medial cuneiform. On the right side of the X-ray, you see the medial margin of second metatarsal is not in alignment. The medial cuneiform is displaced medially here. Can you see this? This is displaced medially. So this is not in alignment. So this is your list. This confirms your Lisfranc injury. Now, next, in your oblique view, this is your oblique view. Let's see with the third. This is your first, second, and third. This is your normal. Third, left side is your normal X-ray in of the oblique view. The medial end of third metatarsal is in alignment with the medial end of lateral, that is the third, lateral cuneiform. But if you see on the right side, the alignment has lost. The lateral cuneiform is displaced medially. You can see this is your lateral cuneiform border. Okay, so be careful. Management is analgesia, neurovascular assessment, urgent orthopedic referral. It is ORIF. Complications, what you can see for is foot compartment syndrome, okay, malunion, midfoot arthritis, flat foot deformity with instability with weight bearing, infections and wound complication, vascular injuries. There are many, but as a near physician, compartment syndrome is important. Okay, there are dozens of ankle fractures, but there are few ankle fractures which they like to ask in the exam is. One is on your left side, you see a triplane fracture. Don't mistake it to be a Mason fracture. At the left hand side is a triplane fracture. There is a fracture of your epiphysis, your growth plate here. This is your epiphysis, this is your growth plate. On the lateral view, you can see the fractures of your metaphysis as well. So epiphysis, growth plate, metaphysis, that is your Salter-Harris 4. This is Salter-Harris 4 type of fracture. Whereas on the right hand side, you can see a fracture of here, a small fracture of your medial malleolus. And in the same patient, there is a spiral fracture of shaft of fibula. The eponymous name of this fracture is Mason fracture. I don't know how you guys pronounce it. Lots of regions pronounce this in a different way. So I pronounce it as a Mason fracture. This means there is a fracture of your medial malleolus and a fracture of your proximal shaft of fibula. Do not forget to mention to write the side of the bone of the fracture. Both are unstable fractures. Both will require urgent orthopedic referral for ORIF. Masonry fracture. It is a tibiofibular syndesmosis disruption. Okay, there is a widening of ankle joint, deltoid ligament disruption, and medial malleolus fracture, and also the fracture of fibula, proximal shaft of fibula. In your triplane fracture, it is Salter Harris 4 type of fracture. Vertical fracture to the epiphysis, horizontal through the physis or the growth plate, and oblique through the metaphysis. Okay. Important things in all fractures: check for neurovascular compromise. Okay, and immobilize it. Complications, what you can see are post-traumatic arthritis, tibial length retardation, angular deformity. Your management should be analgesia, immobilization, needs urgent ortho referral for ORIF. Okay, tibial plateau fracture. So you can have a scenario of again a sports person who has had a tackle, or it can be a car pedestrian versus a car collision. Anything can come up and unable to walk, and they can give you an X-ray. So tibial plateau fractures can be subtle and can be clearly visible. On the right hand side X-ray, you can see there is a definite tibial plateau fracture here. Okay, the whole thing is fractured. Okay, so it can be so evident, and it can be a subtle fracture at the on the left hand side of the X-ray. You can see. What do you mean? First of all, let's see what do you mean by tibial plateau. Is this is known as the tibial plateau, the red line which I have drawn. Okay. Now, if you can see here, there is a very subtle fracture over here. Okay. There is increased bone density. If I don't think if you can notice here, there is an increased bone density over here. Okay. So even a little speckle of increased bone density can indicate a tibial plateau fracture. Tibial plateau fractures can be on the lateral side or the medial side as well. So you need to mention whether it is a lateral or a medial tibial plateau fracture. You need 3 X-rays, AP, lateral and oblique views. They are important because they are more prone to neurovascular compromise and compartment syndrome. Okay, these type of fractures eventually land up in complications. Fractures may be subtle, which may require CT. Hemarthrosis might be present if there is a joint swelling and you don't see a fracture in the X-ray. You do a tap, and if you get blood, that is an indirect indication of tibial plateau fracture. There is a classification which is used for grading the tibial plateau fracture, that is known as Shadska classification. Okay, you can have a look at this one on your, you can Google this and see. I don't think it is important for you to remember. Management is simple: analgesia, immobilization, and orthopedic referral. Okay. One thing you need to remember in Shatskar is that grade 1, class 1 or grade 1 goes home in an immobilizer with a referral to fracture clinic. Rest all grades are admitted in the hospital. Okay. Important thing is analgesia, immobilization, ortho referral. Now, calcaneal fractures. You need AP, AP lateral and an axial view in calcaneal fractures. Look for Bohler's angle. Normal Bohler's angle are between 20 to 40 degree. If it is less or more, it is abnormal. You need to know Bowler's angle. Who would calculate? It is a part A question. If patient had a history of fall from the height, they might give you this X-ray and say your patient had a fall from one floor height and landed on the foot. So what you need to consider is to take an X-ray of the other foot as well to see any calcaneal fracture of the other foot, and also you need to take an X-ray of the spine, because whenever there is a fall on foot from a height, you can have bilateral calcaneal fractures and a wedge compression fracture in the spine. So remember that and take that into consideration. Management is analgesia, okay, and you need to differentiate whether it is an intra-articular or an extra-articular fracture. Now the picture in this one, there is a fracture here. The articular surface what we are talking about is between the calcaneal and tanus. This is your articular, but here the fracture I'll highlight in the fracture is here. So this is an extra-articular fracture. Whenever the fracture extends, I'll highlight in blue. If the fracture extends from here till the articular surface, then it is called as intra-articular. If it is an intra-articular, then admit under ortho and get a CT done. If it is an extra-articular, then put a back slide. Advise your rest, ice compressions, okay, a limb elevation. Advise them to use crutches and fracture clinic follow. But if it is an intra-articular fracture, you need to admit and get a CT done. Metatarsal fractures, these are tricky ones. You can have Jones, pseudo Jones, and stress fractures. Okay, now this I have brought it up because this here, this is known as the fracture line here. This is Jones fracture. Okay, now if there is a fracture here, that is a pseudo Jones fracture. So let us label it in red. This is Jones J. Here this is pseudo Jones P. But if you have a fracture here, that is can be your stress fracture. That can be your stress fracture S. So three different levels, three different fractures. How to remember is shaft of the metatarsal can be a stress fracture. Fracture at the level where there is a meeting of two metatarsals, fifth and fourth here in this area. Fracture in this area, just adjacent to this area is your Jones. Below it is your pseudo Jones. Okay. Now, if the stress fracture shaft of metatarsal of second metatarsal is fractured, it has an eponymous name of march fracture. It is usually seen in people who do march past without adequate shoes. They can have a march fracture. March fracture is nothing but a stress fracture of the shaft of second metatarsal. Okay. First metatarsal needs ORIF. Rest all are usually treated conservatively. Okay. Management is analgesia, immobilization, POP, non-weight bearing, fracture clinic referral. Achilles tendon rupture. You can have Achilles tendon rupture. Risk factors are steroid use, quinolones, renal failure, rheumatoid arthritis, SLE. Clinically, how would you see is a palpable step. You can palpate the Achilles tendon and you can see a obvious step deformity, or you perform a Thompson test, also known as calf squeeze test. On the right hand side, there is a photograph of Thompson test. When you squeeze the calf, there is a plantar flexion. If You fail to see that indicates Achilles tendon rupture. Management is analgesia referred to ortho for fixation. Sorry. Knee joint effusion. This is gonna come in your examination. Okay. Differential diagnosis are prepatellar bursitis, septic arthritis, gout, pseudo gout. These are the major ones. Rheumatoid arthritis, hemophilia, von Willebrand factor disease. Like might get half a mark, but these are important. Now, send a diagnostic tab for gram stain, culture, crystal, cytology, cell count. As a rule of thumb, all effusions are of the knee are septic arthritis unless or until proved. Whenever you have proved that it is a septic arthritis, how would you prove it in your emergency department is you do a diagnostic tab, send for a gram stain. If gram stain comes positive, that means it is septic arthritis. What is the management is your analgesia. Again, I'm saying it again, just don't write analgesia, write what you're going to give. Your broad spectrum IV antibiotics, write what antibiotic you're going to give. Like if I cannot remember of anything, I just tend to write ceftriaxone. Ortho referral for joint wash. But in the examination, if the scenario says a professional like plumber, carpenter, which requires excessive kneeling, and the scenario is showing an aseptic patient without any septic picture, he's taking you to pre-patella bursitis. In that, your management should be NSAIDs. Just don't write NSAIDs. Write ibuprofen 400 mg, TID for 5 to 7 days. Advice for rest, orthopedic follow-up. If a young patient comes in, think of sexually transmitted disease. Think of gonococcal arthritis. Gonococcal arthritis is management is the same as septic arthritis. You need to give analgesia, broad spectrum IV antibiotics, ortho referral for joint was, and advice. Additional what you need to remember is advice for the screening of partners. Okay. Okay. Ottawa rules. You guys need to know Ottawa knee rule and Ottawa ankle rule. You can Google it and remember them. You can ask a question on those. There is also an Ottawa SH rule for subarachnoid hemorrhage. You also need to remember Ottawa knee rule, Ottawa ankle rule, and Ottawa SH rule. Okay, now let's go to the upper limb. What is your diagnosis? What is the why is the fracture unstable? What is your management? A 20-year-old male with history of fall on the right hand while playing football, complain of pain, swelling over the base of the right thumb with painful movements. He has no history of comorbids or addiction. His observations are within normal limits. Distal neurovascular examination is normal. What is your diagnosis? This is Bennett's fracture. Okay. So this is a Bennett's fracture dislocation. Why is it unstable? Is the distal part of the fracture is pulled by the abductor pollicis longus tendon. That's why it is unstable, and most of these patients will require fixation. Your management is analgesia and urgent orthopedic referral. Though some of the Bennett fracture are managed conservatively, but it is the orthopedician's call. So you need to give an orthopedic referral urgently, so they can take a call whether it needs fixation or conservative management. Now, some people must have written this as a gamekeeper's thumb. Okay, so I'll tell you the difference between gamekeeper's thumb and Bennett's fracture. Now in this X-ray, you can see a fracture, comminuted fracture of the base of the first metacarpal, that is your thumb. Base of the metacarpal of your thumb is having a comminuted fracture. When there is a comminuted fracture, it is known as Rolando fracture. If it it is not comminuted fracture, it is your Bennett's fracture. There is a difference. Same place fracture, if it is comminuted, it is Rolando. If it is not comminuted, it is Bennett's. Whereas the gamekeeper thumb, let me highlight it in green. Gamekeeper thumb, you may have an avulsion fracture here. In gamekeeper's thumb, you usually have an ulnar collateral ligament tear. Let me draw. There is an ulnar collateral ligament like this way, and due to this ligament damage, you can have a small avulsion fracture at the base of the proximal phalanx of the thumb, that to ulnar side. So that is gamekeeper's thumb. This is Bennett's and Rolando's. This is the difference. This is your Rolando. This X-ray is your Rolando fracture. What is this? This is the fracture of a neck of fifth metacarpal. This is boxer's fracture. Okay. Your management is analgesia. Check for rotational deformity. If there is a rotational deformity, you need to refer it urgently to orthopedics. If there is no rotational deformity, then you should put on a gutter splint and send for a fracture clinic follow-up. Okay. Any fractures of the metacarpals, you need to check for rotational deformity. If there is a rotational deformity, you need to urgently refer to orthopedic. Okay, let's go to this confusion. One more confusing topic. Describe the abnormality. Immediate next step. Your ED management if your above step is normal. So 45 female fall fall on the outstretched hand over right hand, complains of pain and swelling over right wrist. Her vitals are stable. Your junior gets an X-ray done, which is given below. So what is this? Describe the abnormality. Many of you must have written Colles fracture, but here I have asked to describe the abnormality. So you should describe it as fracture of distal end of radius with dorsal displacement of the distal fragment. If you are like me, egoistic, then you write suggestive of Colles fracture. But when asked for describe, you need to describe, and also you need to write the side. On the X-ray top right side, it is written as right hand. Even in the scenario, it is mentioned as right hand. So description, appropriate description B would be fracture of the distal end of a radius with dorsal displacement of the distal fragment of the right hand, suggestive of Colles fracture of the right hand. Immediate next step would be any fracture. Next step would be your distal neurovascular check. Now your ED management, if the above step is normal, that means you do not have a distal neurovascular compromise. If you have a distal neurovascular compromise, you need to involve orthopedics as soon as possible. But if you do not have a neurovascular compromise, you give analgesia, reduction under hematoma or Bayer's block, write any one, recheck X-ray and distal neurovascular status. Okay, put a Colles cast and fracture clinic follow-up. You can also write as cast advice. You can give cast advice as well. Now, what is your X-ray on the left, total left X-ray? If I ask you to describe your X-ray which is on the total left hand side of this slide, this description would be fracture of the distal end of the radius with volar displacement of the distal fragment of the right forearm. Okay, suggestions of what? This is your Smith's fracture. This is opposite to Colles. This is your distal. This is your distal fragment. This has come On volar side, it is Smith's fracture. If this goes back, that is your Colles fracture. Now always remember, be it Colles or be it Smith's, if you can see an intra-articular extension, that means there is the fracture line is involving the joint also, then it becomes a Barton's fracture. Now if you see in your X-ray A, you will confirm this at a distal radius fracture with dorsal displacement. This one, distal radius fracture with dorsal displacement of your distal fragment. This looks like a Colles, but if you see an AP view, that is your B X-ray of the same patient, here you have a intra-articular extension. You can see there is a fracture line here. Whenever there is this line is your which has coming in between the joint. This is your intra-articular fracture that has involved the joint. Whenever there is joint involvement, it is a Barton's fracture. Okay, do not write Colles or Smith, write Barton's. Now X-ray A and B looks like a Colles but with intra-articular extension, that is your Barton's fracture. But if your X-ray looks like a Smith's fracture with an intra-articular extension, that is your reverse Barton's fracture. Okay, I think this should solve your confusion. So Colles is displacement of the distal fragment dorsally. Smith is displacement of your distal fragment volarly. But if it is a Colles with intra-articular extension, it is Barton's. If it is a Smith with intra-articular extension, it is a reverse Barton's. So Smith's, Barton's, reverse Barton's, all these needs ORIF. They are unstable injuries. They need urgent orthopedic referral and ORIF. Whereas Colles, you can put a cast and send for fracture clinic follow-up. Now next, let us go to scaphoid fracture. These are very subtle fractures because they are very difficult to identify. Usually the mechanism is fall on the outstretched hand and patient will come with complaints of pain over the scaphoid region. Now the scaphoid fracture, as I said, is very difficult to identify, but it is important for you to identify because the scaphoid blood supply, I will just mark the scaphoid for you. This bone is your marking in green is your scaphoid bone. Okay, now the blood supply of your scaphoid bone enters through the distal end. It enters like this. So if there is a fracture at the waist level, this blue line I'm showing, if there is a fracture here, so this part of your bone will have an avascular necrosis. That is why it is important for you to identify these fractures. Okay, they are prone for avascular necrosis if untreated because of retrograde blood supply. That is what we spoke about. 25% of the x-rays are negative. They will have a scaphoid fracture, but you feel it is normal. 25% of the x-ray do not reveal anything. Okay, but you need to see the non-radiological findings as well. What are the non-radiological findings of your scaphoid fracture are pain on compression, also known as telescoping of the thumb, pain on the scaphoid tubercle, tenderness in the anatomical snuff box, pain on ulnar deviation. Your management is analgesia, Colles cast, and fracture clinic follow-up. Take the next available fracture clinic follow-up. Okay. Let the orthopedician decide whether they need a CT, they need an MRI. It's not our problem. Let the orthopedician decide. Our management is analgesia, Colles cast, and refer to follow-up. Okay. Supracondylar fracture are usually seen more in children. There is a Gartland classification. If you can remember, it is well and good. Important thing is that when do you need an urgent orthopedic referral in these injuries are when it it is there is a small table in this slide, top right hand side. Neurovascular deficit, if there is more than 50% displacement, if there is more than 20% angulation of distal part posteriorly, if there is more than 10% medial or lateral angulation. These needs urgent orthopedic referrals. Rest you can immobilize and send to a fracture clinic follow-up. But any of these things you need urgent orthopedic referral. But sometimes the supracondylar fractures are subtle and you do not find any radiological abnormality, then you need to see for anterior and posterior fat pad. Anterior and posterior fat pad. In this X-ray, the red arrows are showing anterior and posterior fat pad. Always remember, anterior fat pad can be normal, but if posterior fat pad is present, it is always abnormal. Anterior can be normal, posterior is always abnormal. But in this X-ray, you can see the anterior fat pad looks like a sail of the ship. If you see this sail sign, this is known as sail sign. If you can see a sail sign, that is abnormal. A normal anterior fat pad can only be subtle, but if there is a sail sign present, that is abnormal. So if you can see anterior and posterior fat pad, but you cannot see any fracture, that is indirect indication of supracondylar fracture. Complications of these fractures are median nerve damage, radial nerve damage, ulnar nerve damage, brachial artery malunion, and myositis ossificans. Lots of complication, but important ones are median nerve, radial nerve. Ulnar nerve only if there is a lot of posterior displacement, then only your ulnar nerve can be damaged. Brachial artery is important. Okay. So your management is analgesia, immobilize with above elbow back slab in 90 degrees flexion, ortho follow up. Urgent ortho referral we spoke about. Now Monteggia and Galeazzi fracture are the important forearm fractures. Both are unstable fractures. Important things is initially you need to check for neurovascular status. You need to give analgesia, immobilize, and urgent ortho referral for fixation since these are unstable fractures. Now, how do you identify? There's a lots of confusion between Monteggia and Galeazzi fracture. So this is how I remembered. I like this cartoon, Monsters University. I think many of you know about it. Monsters University is a very good cartoon. You need to watch it after the exam if you haven't. So, Monsters University, the initials are M and U. So, Monsters is your Monteggia, University is your ulnar. So, Monteggia is having an ulnar shaft fracture with radial head dislocation. Monteggia is ulnar shaft fracture with radial head dislocation. Galeazzi is your radial shaft fracture with distal radio-ulnar joint disruption. Okay, so remember it this way. But both are unstable fractures. You need to give an urgent referral for ORIF. Gamekeeper's thumb we spoke about. It is in this X-ray you can see it is avulsion fracture of the base of the proximal phalanx on the ulnar side. This one. This is your gamekeeper's thumb. Bennett's and Rolando are here where I have highlighted in green. Please don't get yourself confused. This is because this gamekeeper's thumb is because of the damage of your ulnar collateral ligament, which is present here. Whenever there is a damage of pull or damage of ulnar collateral ligament, there can be an avulsion fraction. Okay. So now extensor tendon injury. This is the photo on the left side of this slide. This is your mallets, M for mallets. Now the second picture is your Botania's deformity. Okay, this is your mallets. Left is your mallets and right is your Botania's. Botania's looks like as if you are pressing a button. Okay. Now these both are extensor tendon injury, but at different places. The common extensor tendon divide into two: the central slip and the lateral slip. The central slip in this picture on the right hand side, this is your metacarpal M, this is your proximal phalanx, this is your middle phalanx, and distal phalanx is out of the picture, it is somewhere here. Okay, so now the central slip attaches at the base here, attaches at the base of your middle phalanx. Okay, and your lateral slip extends here and attaches at the base of the distal phalanx, somewhere here. So when there is a injury to your lateral slip, it causes mallet finger. But if there is an injury to your central slip, it causes Botania's deformity. So remember it this way: lateral slip injury is mallets, central slip injury is your Botania's. So what you're going to do is you need to take an X-ray to see if associated avulsion fractures are there. If there is an associated avulsion fracture, that is good for the patient because they have a better prognosis. But if there is no avulsion fracture, the prognosis is little worse. But if avulsion fracture is there, they have a better prognosis. Your job is analgesia, and if it is a mallet finger, you need to put a mallet splint for 6 weeks and tell them to keep the splint always on. Even while they are washing hands, they need to remove the mallet splint and keep the finger on some hard surface to support till they clean up. Okay, so for 6 weeks they need mallet splint and a fracture clinic follow-up. Now this is again gonna come in your examination. Flexor tenosynovitis. Okay, there is cardinal signs known as canaveral signs. These are tenderness over and limited to the flexor sheath, symmetrical enlargement of the digit, fusiform swelling, severe pain on passive extension of the finger, flexed posture of the involved digit. Okay, now if I ask to describe, now if I ask, sorry, the diagnosis of this, then you should tell me a complete diagnosis. It is flexor tenosynovitis of right index finger. Do not forget to mention the site and which finger is involved. Now they can ask you what two things you cannot see in this picture. If present denotes flexor tenosynovitis. So those are your passive extension, pain on passive extension, and your tenderness over the flexor sheath. Okay. So, as I said, do not forget to mention the side and finger involved. Management is analgesia, broad spectrum IV antibiotics, ortho referral for tendon sheath exploration and drainage. Compartment syndrome is a common complication of any long bone fractures or any fractures. Most common sites are lower leg, forearm, hands, and feet. Compartment syndrome can have external forces or internal forces. External forces are self crushing, circumficial burns, restrictive plasters, dressing, or splints. Force from the external side are these: internal expanding forces like fractures, extravasation of an ischemic extremity, or there is an arterial rupture and the pressure inside is building up, severe burns, prolonged exercise. These are internal forces. Either of these can cause compartment syndrome. Like in acute limb ischemia, this is also having 6 P's: pain on passive stretch, paresthesia, pallor, paralysis, pulselessness, poikilothermia. Complications are all these: rhabdomyolysis, renal failure, hyperkalemia, hypokalemia, hypovolemia, local infection, ischemic contractures, neurological deficit, limb amputation, death. Investigations, what you need to do is, as an ER physician, are more bothered about neurovascular, distal neurovascular check and intracompartmental pressure. You need to do an X-ray to see underlying fracture, do a urine bedside to see for myoglobin, creatinine kinase, your renal function test, coagulation screening to see for DIC. Management is urgent orthoreferral for fasciotomy. You need to give strong analgesia like morphine. Now, when is fasciotomy indicated is to calculate delta pressure. How do you calculate delta pressure is your diastolic blood pressure minus the intercompartmental pressure. If it is less than 30 mm of Hg, then it is an indication of fasciotomy. And then also you have to look for complications like rhabdomyolysis and all and treat the respective complications. Osteochondritis or epiphysitis, usually seen in young children. There are different types: crushing osteochondritis, traction apophysitis, osteochondritis dissecans. Crushing osteochondritis types are Perthes disease, which is important, can come up in the exam. Schwermann's is involvement of your vertebra. Kohler's is your navicular bone of foot. Kienbock's is your lunate. Freiberg's is second metatarsal head. Panner's is your capitulum. These are the eponymous names of your crushing osteochondritis. Remember a few of them. But important one for the exam is Perthes disease. So remember that. Now again, one more question which is going to come up in your examination is Osgood-Schattler. Osgood-Schattler Osgood-Schattler is traction apophysitis. Okay, it is a pull. What is this? Osgood-Schattler is a pull of the patellar ligament insertion onto the tibial tuberosity. If you see in this picture, this tendon from the patella comes and attaches to the tibial tuberosity. When this is pulled, you can have an avulsion fracture of the tibial tuberosity. So if asked to describe, you should describe there is an avulsion fracture of the tibial tuberosity of the side of the limb involved. Side is always important. It is more common in 10 to 15 years of age. Okay. Now another variant is Sinding Larsen Johansson. Proximal end of patellar tendon at the inferior pole of the patella. Here, if you have a avulsion fraction here, it is your Sinding Larsen Johansson. The treatment is same: rest, NSAID, immobilize, fracture clinic follow-up. So this is another type of traction apophysitis like your Osgood-Schattler. This involves the calcaneum, traction apophysitis or avulsion fracture of the calcaneum because of the pull of Achilles tendon. This is severe disease. Treatment is same as Osgood-Schindler. NSAID rest orthopedic follow-up. Okay guys, hope this webinar have helped you and gave you a quick revision of your orthopedic question which are gonna come up in your examination. And this is it guys. This is the exam you are gonna get through. I have no doubts. I have more confidence in you guys than you yourself. So keep calm. You know everything. You are the master of this exam. You are gonna clear it. Okay, guys, all the best for your exam. See you.